Good morning, folks. I wanted to thank SAGES for the opportunity to present. I admit when I was given the assignment of Potpourri, for a second I was worried that was like a Jeopardy format. I don't know if anyone remembers Jeopardy Potpourri category. So these are my disclosures. And today I'm really going to talk about two main categories. Number one, bariatric devices, such as the gastric balloon, the Maestro System, which is a vagal blocking therapy. It's also called the V-block, and something called the Aspire Assist. Each of these devices have been available in the US since 2015. And what I'd say is they actually serve an important role, and they fill a niche for the bariatric world where, you know, some people want bariatric surgery and understand it's a very powerful tool, and then some people simply do not want an operation, a big surgical operation to treat obesity. And I think these devices actually serve an important place in our treatment of obesity because, again, the obesity epidemic continues to grow. We're also going to talk about these historic operations, specifically the Jejunoleal Bypass and the vertical banded gastroplasty, and within the context of bariatric history, that everyone's done a great job of kind of going over the band and things like that, but these are things that happened pre-band. And so first I'm going to touch on gastric balloons. There's currently 3 devices available in the US and are used frequently. The Orbera up top you see, the Reshape in the middle, and the Obalon on the bottom. And both the Orbera and the Reshape are devices that are inserted endoscopically and filled with fluid. The Obalon balloon is swallowed by the patient. The location is confirmed within the stomach and then filled with air. And to get a sense of how much volume is in these devices, the Orbera can be filled with anywhere between 400 and 700 mLs of fluid. It's usually tainted with methylene blue, so if the balloon bursts, people will have some signs. Also, the Reshape can be filled with 450 mLs in each balloon, and the Obalon is a bit smaller. It is filled with 250 mLs of gas, and multiple balloons can be inserted for the top and the lower models. These are usually, used in people with obesity, a BMI of 30 to 40. We talked about the insertion. They are usually left into place when they are tolerated for about 6 months, and then all 3 models are removed endoscopically. And I don't want to bore you with weight loss details, but EWL is meaning excess weight loss, so how much of the extra weight do these devices help people lose? And it really varies anywhere between 14 and 50% at 1 year, kind of averaging out around 25%. And to get a sense of how much is that, if someone is very successful with medical weight loss, so diet, exercise, medication, we consider that a good outcome if they lose about 10% EWL. So again, 25% at 1 to 2 years is a nice intervention. And so before I touch on adverse events, I want to give everyone a sense of how many of these devices are actually out there. So since 2015, or between 2015 and 2017, at least 12,000 were inserted in the US, and that's a low number. And Orbera reports that over 270,000 of these devices have been inserted worldwide. So what I want you to take away from this is not that balloons are terrible, more that they are a tool and that they are relatively safe. The most common thing people can experience, however, are nausea, vomiting, pain, reflux after insertion. And this can occur in up to 30% of people, so 1/3 of people. This can then lead to dehydration, sometimes aspiration pneumonitis, and there have been reports of bacterial infections of the balloon. Now, usually these things can all be treated medically. So some of the more serious events that have been reported, and this is when you actually see an FDA report come out notifying consumers about it. Number one is actually, the first one several years ago was acute pancreatitis. So reports most likely from a balloon being overinflated and then pushing posteriorly onto the pancreas and causing acute pancreatitis. Also the balloon causing gastric outlet obstructions. And again, treatment for those things would be device removal. Sometimes these devices break or come open and then migrate through the GI tract and can cause bowel obstructions. In that case, that would require a surgical management. And then the 12 deaths that have been reported, and again, this is in over 270,000 devices, have mainly been related to gastric perforations. Now, I think the challenge with the balloons specifically is when you have 1/3 of these devices causing nausea in people is diagnosis. So being able to differentiate someone is 3 days out from their balloon placement, they're having nausea and vomiting, is that the natural course of this device, or is it because they have a gastric perforation and need a treatment? So, tools for diagnosing this would be an upper GI study or a CT with oral contrast. And I think the most important thing, again, is just making this diagnosis. For removal, if you're comfortable endoscopically, you can use a needle knife or a device like that to open the balloon and then remove it with a grasper. If that's something you may not be comfortable with, also consulting a GI, because basically it's a big foreign body removal from the stomach. Or if it's 2 in the morning, hey, GI. No, I'm just kidding. So the next thing I'm going to talk about is, again, it's the Maestro System, but we call it the V-block. This is a vagal blocking therapy, and the idea is this device comprises of these, can you see a pointer? Perfect. These leads that are placed around the anterior and posterior vagus nerve, and they provide electrostimulation that may lead to changes in satiety and appetite. And again, the indications are for those with obesity. These devices are laparoscopically inserted, and they also need to be removed laparoscopically. And what we see is about a 21% excess weight at 2 years, so slightly better than a medical weight loss approach. And I would say the main adverse events for the V-block are device malfunction. So looking through the reports, et cetera, you just see the leads are not communicating well with the neuroregulator, et cetera. The second most common thing is pain at the neuroregulator site, and this can occur in up to 25% of people. People can also have some GI symptoms, dyspepsia, nausea, et cetera. And again, this can occur in up to 25% of people. There have been reports of some retrosternal pain and rare infections or hematomas at the neuroregulator site. But overall, these devices are fairly well tolerated. Now, in a very small series that looked at explanting about 30 of these devices, half of the people cited inadequate weight loss as their desire to remove these. So if you come across someone with a V-block, they're most likely not going to have an acute problem. And so again, the recommended removal approach would be a laparoscopic approach. And if it's not something acute, I think that is something you could triage to a bariatric center if you didn't feel comfortable removing this. The final device I'm going to touch on is something called the Aspire Assist. And I would say this functions very much like a glorified PEG tube in a way. Now, the way it works functionally, it's a PEG placement, so endoscopic placement. This portion is meant to go up into the top of the stomach. People, are told to chew their food very, very well. And apparently about 20 to 30 minutes after a meal, they connect this contraption to the skin and then pump out about 1/3 of the food in their stomach. The way this device works is this connector allows for 115 cycles of this pumping. So people have to pace themselves. This usually will last someone for about 5 or 6 weeks, and then they will need to go see their bariatric program for a connector replacement. And so the EWL reported, again, 48% at 2 years is, from an objective view, pretty good. Now, the majority of the complications that occur from this device, after doing some reading, are mainly complications that you're going to see with PEG tubes or G tubes. So everybody here knows, for the most part, how to take care of these. So some things that have been cited is fracturing of this external port here, buried bumpers where the bumper, which should reside within the stomach, comes out and rests between the stomach and the abdominal wall. The A tube, which is this aspiration tube coming uncoupled from the internal bumper, or the A tube rotating down into the pylorus. Some other things people see are sometimes leakage around the tube, which we can see frequently with any sort of feeding tube. And with the tube removal, it's rare, but people can form fistulas. There has been one report of peritonitis after insertion of the tube, but there haven't been any deaths, etc. If people have a complication, this is something that can be removed endoscopically. Number one, removing the skin port externally, and then endoscopically grabbing the tube and pulling it out. So this is more of a tidbit. So if you're interested, as we come across more and more surgical devices, how can you access reports of adverse events? Now, number one, you can go to the manufacturer's website. Again, that might not be the most objective place. You may look in the literature, but some of these things are so new that there won't be anything published. And so this is a really nice website. It's called the MAUD database. It's on the FDA website. And this is where manufacturers are required to actually disclose any adverse events that happen with their devices. So there's a simple search, there's a more complex search, but you can put in V-Block, Aspire Assist, or Bara, and all the adverse events will come up, and it will give you a sense of what's going on with that device. So briefly, I'm going to talk about these historic operations. And again, this is pre-band era. So the Jejunoleal Bypass was popular in the 1960s and the 1970s. You can see the proximal jejunum here was divided. These two used to be connected and reconnected to the terminal 10 centimeters of ileum. And this created a functional short bowel syndrome. And we don't see the early complications anymore, which were some fluid electrolyte imbalances, diarrhea, kidney stones, and sometimes liver disease or acute liver failure. But you may come across some of the late complications. The later diarrhea is usually caused by bacterial overgrowth of this long limb here. The kidney disease can be related to chronic fluid or low fluid volume status. And the liver disease, it's interesting, they hypothesize that this is actually caused by a combination of hepatic steatosis as well as protein calorie malnutrition that can lead to chronic inflammation in the liver and the pathway down fibrosis, cirrhosis, liver failure. And so, if you come across someone who had a bariatric operation in the 1960s, 1970s with, renal dysfunction or liver dysfunction, the main thing is identifying that they have this operation, because this would most likely require some sort of reversal or revision surgically. Finally, I'm going to touch on the vertical banded gastroplasty. So this follows the Jejunoleal bypass in our history line. Popular in the 1980s and early 1990s. The way this works is a small stomach pouch was created by placing a silastic ring or mesh around to create an outlet and a vertical staple line. And so what we see, and this is something that you very well may come across with patients coming through with a problem, and the main problem people experience is going to be a stricture at this point. That can cause vomiting, dysphagia, reflux, etc., weight loss. The band can also erode here, and we'll talk about treatment options. Finally, if this staple line breaks down, you're going to see a gastrogastric fistula that may result in weight regain. So for specifically the band strictures, the nicest treatment I've seen is actually for an endoscopic approach where people can place a stent through this area, and if the band is partially eroded, the stent will actually complete the erosion process and the silastic band will stick to the stent. After it's left in for about 4 weeks, you can remove the stent and the band will come with it. That's a very nice treatment because sometimes these patients are challenging. Another very nice endoscopic treatment of this is actually placing a port through the stomach and then firing a stapler up into this remnant. And again, I think for those complications, it's good to just refer to a bariatric center. And that concludes our potpourri. If you have any questions.
Thank you.